So thank you so much. First of all, I would like to thank the Vietnamese Dialysis Association for the invitation I have got. This is for me a very, very big pleasure to take part in such a big event. Thank you again so much. So let's go directly to my presentation because we do not have much time for this topic, big topic, yes, about the hemodiafiltration. The title is Defining New Standards. Here, HDF stands for hemodiafiltration, which is a combination between two different dialysis techniques. The one is the common hemodialysis, and the other one is the hemofiltration. Just to understand the HDF, the physical aspect, let's go first through these two types of techniques. Then you will understand better the meaning of HDF. First, the common hemodialysis. You see here the blood circuit and then the dialysate circuit here. Yeah. So important here to know is that the removal of all the substances, the toxins, is done by so-called diffusive clearance, because there is a difference of concentrations between blood side, blood compartment, and dialysate compartment, so that the molecules from the higher concentration will run automatically per diffusion into the lower concentration. In this way, we remove many, many substances, we adjust many concentrations, and so on. Important in this type of clearance, the diffusive clearance is the main clearance in HD, and important is to know that here we better remove small molecules and not that good larger molecules, yeah, because the diffusive clearance also depends on the size of molecules. Again, electrolytes, small toxins like urea, creatinine can be better removed than other, for example, middle molecules, okay? This is very important in common HD. Let's go to hemofiltration. You see the same blood circuit like before, but here we do not have any dialysate flow, because here we just remove fluid. We separate plasma water from blood. By this separation, we also remove other substances which are diluted soluted in plasma water, like the toxins, yeah? So this type of clearance we call convective clearance, convection, yeah? The convection does not depend on the size of molecules, but the convection depends on the total volume of ultrafiltration. The more the ultrafiltration, the more is the convective clearance for small and larger molecules. And this is the reason why in this treatment we infuse a substitution solution into the patient in order to remove it again. In this way, we increase the UF volume, and so we increase the adsorption. Yeah, okay, adsorptive clearance. So since in these treatments we have to use high flux filters because we need a high permeability due to the high ultrafiltration, we use high flux filters, and high flux filters are usual synthetic membranes, so that these synthetic membranes are also have a thick wall. And so this thick wall increases the adsorptive area inside. So we have in such filters also a good adsorptive clearance. Okay, so remember, in common hemodialysis, we can better remove small molecules. In hemofiltration, we can better remove larger molecules. And so the combination in both we can do, both techniques we can do in one, and so we have HDF. You see here the dialysis, the same blood circuit like before, and you have the dialysate circuit here. So that means we have a diffusive clearance, good for small molecules, and we have a substitution solution infusion so that we can increase the ultrafiltration volume. So that means we have a good convective clearance. Also, the adsorptive clearance is good because we use here high flux filters with high adsorptive internal area. Okay, good. This is the principle, the physical principle of HDF. The big advantage here is that we can remove well small and larger molecules, which you can see it here in these curves. This is a study comparing clearance in different modalities of treatment, depending on the size of the molecules. Yeah, you see in HD, for example, where we have just diffusive clearance, we can better remove urea, creatinine as a small molecules. But when the molecules become bigger and bigger and bigger, they have in the range of middle molecules, like here in beta-2 microglobulin, no more clearance. Yeah. Compared to that, you see the HF. The HF, I told you, the clearance in HDF, because we have convective clearance, does not depend on the size of molecules. That's why this linear curve here. That means the advantage here is we can well remove larger molecules. Good. And when we combine HD and HF together in HDF, the yellow curve, you see the profile of clearance is quite good. Good clearance for small molecules and good clearance for larger molecules. So this is the big advantage of HDF. Okay, so let's continue now. Let's go on. The HDF, how do we do this HDF? What is the practical size? Today, we do so-called HDF online. What means online? Online means that the dialysis machine itself can prepare the substitution solution, yeah, because we need a lot of fluid, yeah, we need a lot of solution. Let me do one example. In post-dilution, this solution, in post-dilution means we can connect this solution in post-dilution. This means after the filter, like you can see it here, and we can connect it, or we can connect it in before the filter. Then we call it pre-dilution. Here we have to infuse a lot of fluid just to improve the convective clearance. For example, in post-dilution, we usually give around 4 or 5 liters per hour, around 20-25 liters in 1 4 hours session. This is a lot of fluid, yeah? And this fluid has to be prepared by the dialysis machine. That means this fluid is a part of the dialysate prepared by the dialysis machine. Only this substitution solution, because it goes into the patient, it has to clean quite well. Okay, good. In such a treatment, we need a dialysate flow of around, which is the standard one, 500 milliliters per minute. Yeah, the standard dialysate flow. Here in HDF treatment, we need a little bit up to 600 milliliters per minute, because we need a part of this fluid to be used as substitution solution. Yeah, okay. So now you understand what. Now, how does the machine prepare this solution? And you will see this soon. This solution, important is that this solution is cleaned. There are no bacteria inside, and there are no endotoxins inside. That's why we have so-called microbiological requirements by our standardization institutes, like the ISO norm of 23500 here. Yes, this is the newest norm, and this norm sets or recommends the limit for such concentration in such a fluid. For example, here you see we take the tap water, we clean this tap water through the reverse osmosis. Yeah, we filter through the reverse osmosis, and then we get the dialysis water for every dialysis machine. And the concentrations of bacteria and the endotoxins in such water should be up to 100 CFU for bacteria and up to 0.25 units per milliliter for endotoxins. Yeah, and this water quality is the basis quality for all dialysis machines. The dialysis machine take this water and mix it with concentrates, acid and bicarbonate concentrates, and so we get the dialysis fluid, the standard dialysis fluid. Yeah, so also this fluid should have bacteria up to a maximum 100 CFU per milliliter and endotoxins up to 0.5. Yeah, we can use this water in a standard low flux dialysis. Now, when we want to do more, this quality for our HDF therapy or high flux dialysis is not good enough. We have to clean again such a water. Yeah? And so far, this dialysis fluid goes through an ultra filter, so-called DF filter, which is very fine filter and which removes many, many bacteria and endotoxins. And so we get so-called ultra-pure dialysis fluid with concentration with limits of 0.1 for bacteria, 0.1 CFU, and 0.03 endotoxins. You see, extremely low concentration. And we can use this dialysis, ultra pure dialysis fluid for high flux dialysis, or also we can use for HDF. Just to be sure, this quality would be already enough, good enough for HDF. But just to be more sure, usually the dialysis machine, which is able to do HDF online, can filter this fluid again one more time through the same filter, through a second, a similar, identical filter, which we call HDF filter, is filtered again. And so we get sterile substitution fluid with concentration of maximum 10 by -8 CFU and endotoxin 0.03 units per milliliter. So this is the way how we clean, how our dialysis machine cleans this water. Now, important is that when the machine has these filters, DF filter and or together HDF filter, it's not necessary to test every time the quality of such water. So far, it is okay. For example, in Germany, we test the bacteria and the endotoxins in such fluids just every 3 months, as we do it usually for dialysis water after the reverse osmosis. Okay, good. Let's continue. And you see here in the circuit here how inside the machine does clean this fluid. Yeah, you see here from the balancing chamber is coming dialysing fluid, 600 milliliter per minute. I told you HDF is a little bit more. It is filtered the first time. We get ultra pure dialysing fluid, and then another part which is going as substitution to the patient is filtered a second time. Yeah, and so we get sterile, really sterile solution. We call this type of sterilization cold sterilization. Yeah, it goes all to the patient and comes then back through the dialyzer back into the machine to the balancing chamber, and the balancing chamber can control all this fluid going to patient and dialyzer and coming back from them. All these fluids are balanced by these volumetric chambers. So far, the system is also in terms of volumes very, very accurate. Yeah. Okay. Good. Let's continue here. These are such filters, and you see DF filter. We can use this filter also as HDF filter. Yeah, it's the same. These filters are also capillary filters. You see one capillary here, and the membrane can be also, for example, polysulfone membranes. And you see inside these such synthetic membranes have inside a huge area. You can see it here, huge area. Yeah, and so this area can absorb a lot of substances. So the cleaning of such fluids to get ultra pure dialysing fluid is done by such filters per filtration and also per adsorption. Yeah. So the other thing is that we can reuse such filters up to 150 treatments or 900 hours. Yeah. The machine can do this fully automatically, the cleaning of these filters after every treatment. These filters are very effective because they have a retention capacity of 10 by 6. That means when you, before the filter, have 1 million of endotoxin particles, after the filter, you will find only one. And this is very, very good capacity. Such filters are cleaned after every treatment, also are sterilized or disinfected by citric acid. Is a good material to disinfect such filters, yeah, because not too much aggressive. Okay, let's continue. From clinical point of view, you see for doctors, for example, you don't need to do special things when you do such a treatment, HDF online treatment. You don't need to do special tests, special evaluations, and so on. So important is that you have regular disinfection of dialysis machine. After every treatment, we should disinfect, decalcificate, and disinfect the machine, for example, by citric acid. Then, regular monitoring of microbiology. As I told you, it's not necessary to do it before every treatment, just every 3 months, for example, it's more than okay. Yeah. So, and then regular replacement of DF filters. I told you we can reuse such filters up to 150 times. That means the machine will tell you when the time is over, it will tell you to change the filters. And it is very, very easy to change such filters. Regarding the patient, we have to take care of the clinical symptoms, for example. Just observe clinical symptoms. When the fluid is, for example, not okay, the patient will get shivering reactions, fever reactions, and so on. And we can see it. Yeah, we can also measure the C-reactive proteins, which is a good indicator for such reactions, endotoxin reactions, and so on. And you, as doctors, know well the concentrations, the normal concentrations, the increase of CRP, and so on, and then you know what to do. So this is enough. This is what you have to take care. Yeah, more special tests, special checks are not necessary usually. Okay, let's continue here. Clinical parameters. Usually we do this treatment, we give the substitution in a post-dilution because post-dilution is more effective. Yeah, pre-dilution is less effective because of dilution effect before the dialyzer. Yeah, we do post-dilution, but when we do post-dilution, we have to take care of one physical aspect. The ratio between blood flow and total UF flow, the so-called filtration ratio, should be not more than 25–30%, because in case we remove too much fluid from blood, the hematocrit would increase too much and we would get clotting problems in the filter. This is important, but also this is controlled by the machine. And this also means that in post-dilution, the volume of substitution which we infuse into the patient is also limited, yeah, which depends mainly on the blood flow. And so far I have I showed to you 2 examples. One blood flow with 300 milliliters per minute and another one of 400 milliliters per minute. And you see, when we set post-dilution with 25% filtration ratio, then the maximal volume we can infuse in this treatment is 16 liters. Yeah. On the other hand, you see blood flow, when we increase the blood flow to 400, for example, you will see that the substitution volume is increased to 22 liters. Usually, the right dose in post-dilution is between 20 and 25 liters per session. We used to distinguish, you will see this in the next slide, distinguish between low efficiency and high efficiency HDF. But before, just a few words about pre-dilution. Sometimes we also use pre-dilution, for example, when we are not allowed to give any anticoagulation to the patient, no heparin, nothing. So we can do pre-dilution because this can dilute, can rinse the filter, so avoiding clotting. Okay, Good. And usually in pre-dilution, we give the double volume usually. When we in post-dilution give 20 liters, in the pre-dilution, we can give up to 40 liters, 50 liters, because here the filtration ratio in pre-dilution is not important. And you see here what I mean with low efficiency and high efficiency HDF. The definition is just by the substitution volume. When the substitution volume in post-dilution is up to 15 liters, we call this low efficiency HDF. When it is more than 15 liters up to 25 liters, then we have a high efficiency treatment, HDF. Yeah, good. And this is here down again, pre-dilution, what I told you before already. Okay, good. So this regarding the different terms and so on, this is important to understand then the clinical studies about such treatments. Medical aspect. You see here a list of potential indications for HDF online. Cardiocirculatory instability, that means patients suffering from hypertension during the treatment, high volume high UF volume, therapy-resistant hypertension, elimination of middle molecules, uremic polyneuropathia, hyperphosphatemia. These are all possible indications. And finally, another important indication is dialysis-associated amyloidosis. I have here pointed out these two, the hypertension and the amyloidosis, because these are the most important indications. Regarding the hypertension, it seems that the patient in HDF get less hypotensive events during the treatment, and maybe especially old patients and diabetic patients, yeah, mainly because we have here, due to the substitution solutions, we have an increase of peripheral vascular resistance as a contra reaction of high ultrafiltration, and we have less reduction of extracellular osmolarities due to less loss of sodium. You know that the substitution solution has also a good concentration of sodium. Okay, so these are maybe the reasons why the patients seem to be more stable in such a treatment. Let's come to dialysis-associated amyloidosis. And you see here, the amyloid is a small polypeptide, very small polypeptide with a molecular weight of around almost 12,000 Dalton. One of these is the beta-2 microglobulin. Usually, we also produce beta-2 microglobulin. Usually, we can remove it very easily by the kidney, but our patients cannot do this. Our common dialysis cannot do this well. You remember I told you we can better remove by diffusive clearance small molecules and not that good larger molecules. So far, this is important here. These patients will accumulate during the years, many years after, for example, 5 years, will accumulate beta-2 microglobulin in the body, especially in the bones, yeah? Especially in the bones, it comes to an amyloidosis, yeah? The patients get problems with pathologic fractures, arthropathy, and especially carpal tunnel syndrome. Carpal tunnel syndrome is a typical late complication in our chronic dialysis patients. We used to say even when the patient is long time enough under dialysis, he will for sure get these complications. And so far, this is important not only to treat such a complication, but also to prevent it. And you see here the clinical picture of such a complication. You see the typical in the patients is the so-called guitar string sign here. This is maximal extended hand here, yeah? Patient cannot extend the fingers more than this. And you see also the tendons, and you see the atrophic muscles here, yeah? So when it comes to such a complication, it is easy to treat. By surgery, we can remove the amyloid in the carpal tunnel. Here, you see it here, yeah? So, but also, of course, more important is the prevention, yeah? And we can prevent such a complication by different things, by, for example, improving the biocompatibility of the treatment and by having convective therapies like HDF to remove such big molecules. So recommendable is to use high permeable synthetic membranes like polysulfone, for example, to have ultra pure dialysis fluid. You have seen now how we do it, yeah, and to treat convective treatments, therapies like hemofiltration or hemodiafiltration. In this way, we can well remove the amyloids, the beta-2 microglobulins, and so prevent, not totally, of course, but we can reduce these complications. And you see this in several studies, for example. Here, this is a very, very old study, but I like to show it because already in the 90s, we knew about this problem and we knew how to solve these problems. Here you see a study with a cohort of patients treated by common dialysis. You see, after 16 years, it begins after 3 years, this complication began after 3 years, and after 16 years under dialysis, almost 90% of the patients have got these complications. What they have done in this study was then they have just cleaned the dialysis fluid, yeah, removing the endotoxins from the producing ultra pure dialysis fluid. And you see the problem is reduced significantly after 13 years. Only 30% of the patients have got these problems compared to almost 70% of the patients in a common dialysis. Yeah, so this is a significant difference. Meanwhile, now in the recent years, this has been confirmed in other studies, like here in this study in 2014. Yeah, here reduce the incidence of carpal tunnel syndrome, and this is probably due to ultra pure dialysis fluid, due to biocompatible material, as I told you, causing less inflammations. Synthetic membranes, polysulfone membranes are quite good for that, and due to removal of beta-2 microglobulin. Yeah. So also other studies show similar results, like the AGE study from Turkey. Yeah. Here they have one conclusion is ultra pure dialysate is associated with a lower risk of cardiovascular events among subjects with more than 3 years of dialysis. Yeah, so you can see how many advantages. Later, I will show very, very shortly other studies. Here, when you do HDF, when you change the patient from HD to HDF, you don't need to change much in the prescription of the treatment, yeah, regarding sodium, regarding potassium, calcium, magnesium, and bicarbonate. You just treat the patient as usual, and when it is, you check the values, the results, and when it is necessary, then you can adapt a little bit, yeah. It's not necessary to change too many things. Also regarding the anticoagulation, in anticoagulation, you should take care that when you give unfractionated heparin or low molecular weight heparin before the dialyzer, you might lose more heparin due to the higher convective clearance in the filter. Yeah, you should know this. And when you give an initial bolus before you start the therapy, you should give it into the venous side and wait a little bit, 3-5 minutes, until you start the blood pump. Yeah, you start the therapy. Furthermore, several outcomes, beta-2 microglobulins. You see here in HDF, we have more removal between 30 and 40%. Yeah, in high flux compared to high flux dialysis, and we can decrease the beta-2 microglobulin, circulating beta-2 microglobulin decline of 10-20%. Regarding the phosphate, also here better results. The mass removal of phosphate is enhanced by 15-20%. This was the study of Lornoy. And also pre-dialysis serum phosphate has been reduced by 6%. The targeted pre-treatment serum phosphate also improved from the 64% to 74%. Let's continue here. Just as I told you already, less hypotensive episodes. You know now, you see, this has been confirmed in this study here, and you know why. That means one conclusion is that the reduction of hypotensive events results in better cardioprotective effects. Quite important. We have also low inflammatory profiles because we are using better biocompatible membranes, and so this the inflammatory profile is much better. Also, better anemia. Anemia correction is better and less consumption of erythropoietin stimulating agents. So the time is almost is over, but just 2-3 slides about the studies. Yeah, here we have done a lot of studies comparing common dialysis, high flux dialysis, low efficiency, high efficiency HDF, and so on and so on. Different studies like the so-called French studies within the DOPS program in Europe. Yeah, and so they come all to similar results. Yeah. The HDF may improve patient survival. Other important studies are, for example, the contrast study, the Turkish online HDF study, the S-Whole study done in Spain, and so on. These come all to similar results. Yeah? Conclusions are in HDF group trend for reduction in cardiovascular mortality, and maybe relatively high doses of HDF improve the mortality. So you see, we get more and more confirmation of such promising results. Yeah, and meanwhile in Europe we are doing a big study called Convince, where we will see, we expect to get same results. Last one. These four studies you have seen before: French study, contrast, Turkish online HDF study, SO studies. These have been again analyzed in a meta-analysis here, and this also confirms that HDF decreases all-cause mortality by 14%, fatal cardiovascular diseases mortality by 23%. And you can see it here, this comparison between HD and HDF. You see the difference between regarding the non-cardiac and cardiac fatal events are quite significant here. This reduction here is quite significant. And I think this is now the last one here. These studies really show are really promising studies and show better results using especially high volume HDF, means high efficiency HDF, means with substitution volumes between 20 and 25 liters per session in 4 hours. Yet also not only the all-cause mortality, but also the cardiovascular disease mortality is here also improved. And this was the last one. Thank you so much. You have seen last minutes I was very fast because we have not much time to do that. But I hope I could explain to you well, that you could understand and you have understood what is the most important doing HDF online. So again, thank you so much. And I close the session with this here. Thank you and bye-bye. Later we will do the questions and answers. Thank you so much. Bye-bye.